Thank you, Chair, for your kind introduction. And I would like to thank Professor Tsitsika and the organizing committee for giving me the opportunity to give a lecture in the International Conference on Social Pediatrics and Children's Rights. I will talk about gestational diabetes in refugee and immigrant women. And to talk the same language, just give some definitions. Gestational diabetes is defined as hyperglycemia first recognized during pregnancy. Immigrant is a person who comes to a country to take up permanent residence, and a refugee is a person who has escaped from. Okay, thank you. From her or his country due to political, religious, or economic reasons, or because of a war. Some facts about diabetes. In 2021, the IDF Diabetes Atlas reported that 10.5% of the adult population had diabetes, with almost half unaware that they are living with this condition. Over 90% of people with diabetes had type 2, and by 2045, IDF projections show that 1 in 8 adults will be living with diabetes. About GDM, the gestational diabetes, global prevalence ranges between 12 and 18%, and the prevalence is increasing in parallel with increasing maternal age, obesity, and type 2 diabetes. I'm not going to talk about the complications, short or long term, of gestational diabetes to the mother and offspring. I think that you know them, but I will stress on financial burden. So the direct cost rise to 1.6 billion USA dollars, mainly due to complications. And gestational diabetes market size was valued at 8.63 billion United States dollars in 2023. So the burden is too big. Now, about the refugees and immigrants, in 2022, 5.1 million people immigrated from to the Europe from non-European countries, and at this year, 5% of the population were non-European origin. Women account for almost 50% of all international migrants, and 50% of these female are estimated to be of reproductive age. So, as far as it concerns the first-time asylum applicants in Europe, 45% were Asian, 22% African, and 14% North and South American. Syrians, Afghans, Venezuelans, and Turks lodged the most asylum application in the EU. So, in bibliography, we know from publications from UK, the Netherlands, Sweden, Norway, and Denmark that in first generation immigrants, there is a higher risk of all types of diabetes during pregnancy, particularly of gestational and pre-existing type 2 diabetes. And let's see some interesting works. Here is the ProRef study that it has to do with pregnancy and obstetric care for refugees in Germany. And there were two questions to give answer to this study. First, are there differences in the frequency of GDM between women of self-defined refugee that we're going to call them SDRS, immigrant women and women born in Germany? And the second, does the perinatal outcomes of GDM differ depending on the migration status? So the authors concluded that SDRS were tested for GDM significantly less often than immigrant or women born in Germany. GDM rate was higher among immigrant women, than among women born in Germany or the SDRS. And the GDM rate varied depending on country of origin, and the highest rates were from Vietnam and Turkey. The perinatal outcomes among women with GDM did not differ depending on the migration status. Another study was about the regional of origin and the incidence of GDM, and assigned women Caucasian race, Middle East and North Africa race that we're going to call MENA, Asia, and Saharan Africa race. And they assessed all anthropometric characteristics, glucometabolic parameters, and dietary habits. And the authors concluded that the Caucasian were older and had a higher blood pressure and an adverse lipoprotein profile. Non-Caucasian had higher body mass index and were more insulin resistant. All groups had distinct dietary habits, and the prevalence of gestational diabetes was higher among women from MENA and Asian countries, and fasting glucose and early gestational insulin resistance, as well as higher body mass index in women from Asia, were identified as important risk factors in Caucasian and non-Caucasian patients. Here is another study about the incidence of type 2 diabetes after gestational diabetes. It was done in Denmark with 20,853 women. 22.3% were migrant and 55.5 were Danish. And the follow-up time was 7.3 years. And they found 10.9% register with type 2 diabetes after pregnancy with GDM. And they concluded, the authors, that the migrant women had higher rate of insulin resistance or type 2 diabetes compared to Danish women. Migrants from Sri Lanka and Pakistan presented an early onset of type 2 diabetes compared to other migrant and Danish women. And the country of origin was an important risk factor for type 2 diabetes in women with GDM. So, okay, now we know, and it is well established that first generation immigrants has a higher rates of diabetes. But what about the second generation? Do they have a higher rates of pre-existing and gestational diabetes? And this is very important because second generation immigrant women are of particular interesting because they represent a growing part of the female population in many European countries. And in addition, second generation immigrants may often adopt a different type of lifestyle than their parents and subsequently face different types of health hazards than the first generation. So this is a nice study published on 2023. And it was done on Swedish population. And the study population was second generation immigrants. That means that they had at least one foreign born parent, and the control group consisted of Swedish born women, where the two parents were Swedish born. They included all women with all type of diabetes during pregnancy. And I will present you only this table that it has the model 3 that is adjusted for age, region of residence in Sweden, educational level, marital status, neighborhood deprivation, comorbidities, smoking, body mass index, and family history of diabetes. And as you can see in yellow, the overall risk of diabetes was increased. Hazard ratio was 1.11, particularly in women with at least one parent from Denmark, Eastern Europe, Africa, and Asia. This is in pink. And as it concerns comparison of GDM versus pre-existing diabetes type 1 or 2, you can see in pink on the table that the overall risk was increased 1.27, especially for the population from Eastern and Central Europe, Africa, and Asia. And the risk for pre-existing type 1 and type 2 diabetes was not too high. So the study shows that the overall adjusted risk for any diabetes in pregnancy in second generation immigrant was 1.18 compared with 1.69 in first generation immigrant. It was less, and this reflects the importance of environmental influences on this population. And they shows that second generation immigrant had increased risk for both gestational diabetes and pre-existing diabetes type 2 compared to non-immigrants. This is very important because this elevated risk across multiple generations in immigrant families call for increased awareness and tailored prevention of diabetes during pregnancy, which is currently not part of routine clinical practice. So there are many challenges for the future. Some of them are on screening and testing for gestational diabetes because, as you know, the screening approaches and diagnostic criteria for GDM vary across settings. Ethnicity is a risk factor listed in testing for GDM in some, but not all countries. Ethnic differences in risk factors for GDM confuse. For instance, Asian population develop type 2 diabetes and gestational diabetes at lower body mass index than Europeans. And immigrant women may experience additional barriers to assessing and navigating health systems. Barriers include language and communication, as well as cultural issues. For example, incongruities between the recommendations, tailored dietary recommendation to eliminate foods such as rice and white bread. And of course, non-residents do not have full health insurance to routine pregnancy follow-up. About maternal and neonate outcomes, refugees and immigrants do not have higher rates of negative outcomes, but other barriers like eating healthy foods and living in affordable and safe areas and specific recommendation which may lead to confusion does exist. The long-term outcomes and the postpartum follow-up, it's a problem. There is very limited evidence about all this stuff. There are some studies in Canada that they found 6 to 23% increased the risk in developing type 2 diabetes. In the United States, especially for Asians, that they have twofold the risk for type 2 diabetes. But there is no adherence to postpartum follow-up. It's generally very low, and the immigrants and refugees underestimate their future risk of diabetes. Some refugees, and this is very important, may also be dealing with traumatization and other consequences of war and persecution. In this context, the potential development of type 2 diabetes may take second place in comparison with more immediate and pressing issues in everyday life. So to conclude, there much remains unclear about the pathways linking international migration and gestational diabetes and its associated adverse outcomes. Asserting that it is merely a question of ethnic phenotype or genetics also appears too simple aspect. And this issue needs to be urgently solved, given that GDM is a preventable situation and preventive intervention are most needed. Further investigation will provide useful insights into improving the health and healthcare needs of migrating population and enable inclusion and culturally appropriate healthcare practices, thereby improving the health of our current and future generation. To that point, we will present you our effort with the establishment of the unit of pregnancies, complicated metabolic disorder in our clinic in Alexandra Hospital. In the first department of obstetrics and gynecology. And you can see the networks between the obstetrician, the pediatrics and pediatricians, the neonatals, the endocrinologists, midwives, and nutritionists. And we are trying to give the best to this population. Thank you very much.